Now I'll hand over the webinar to Dr. Perrone, but first let me highlight a few things. First, please note that the webinar is being recorded. Hold on just a second. The webinar is being recorded, and also here is our activity disclaimer. And here also is our disclosure policies. Please note that this patient education session is supported by sponsorship in the PKD Foundation from UPSCA Pharmaceutical, Inc. And now for what we're finally here for, Dr. Ronald Perrone. Dr. Ronald Perrone is a member of the Division of Nephrology at Tufts Medical Center and the Professor of Medicine at Tufts University School of Medicine. He has had a long-standing and wide-ranging interest in ADPKD, focusing recently on clinical trials and use of total kidney volume as potential regulatory endpoint. He has served as the clinical lead of the PKD Outcomes Consortium, which has led to qualification of total kidney volume as prognostic biomarker by FDA and EMA. Dr. Perrone has participated in a number of clinical trials in ADPKD, serving as the Boston site principal investigator and the member of the steering committees for the HALT PKD study, the Tempo 3-4 and Reprise trials of Tolvaptan in ADPKD, the TAME PKD study of metformin, and the Van Glutstadt study. He also serves as the Boston site PI for Tolvaptan and bardoxolone studies. And now I will hand this over to Dr. Perrone.
Thank you very much. So I'm going to review what is total kidney volume and why is it important to me. Melanie, I need control of the slides, please.
And you should have them. Here we
go. Thank you. These are my disclosures. So I've received research, all of my disclosures are in the area of polycystic kidney disease. So I've received research funding from a variety of sponsors and have been consultant to a number of different companies that have been involved in clinical trials in polycystic kidney disease. Next slide, please. So the objectives of this lecture are to disseminate information about total kidney volume with respect to how it is measured, what it measures, and its implications for disease progression, to educate on what treatments have been shown to affect total kidney volume measurements and how to discuss options with the healthcare team, and to empower patients with ADPKD and their caregivers to better engage with the healthcare team. Next slide, please. So autosomal dominant polycystic kidney disease, or ADPKD, is a hereditary kidney disease associated with bilateral kidney cysts, that is cysts in both kidneys, a progressive decline in glomerular filtration rate, abbreviated as GFR, leading to kidney failure in about 50% of patients by the mid to late 50s. It's the fourth most common cause of kidney failure. There are manifestations outside the kidney, including the liver and heart valves and brain aneurysms, and then all of the issues associated with chronic kidney disease. Next slide, please. So the kidney manifestations of ADPKD are, of course, cysts throughout both kidneys, and these cysts lead to a steady increase in total kidney volume with acute and chronic pain, kidney enlargement, a progressive loss of kidney function, ultimately leading to kidney failure, as I've described, high blood pressure, resulting cardiovascular disease, blood in the urine, cyst infection, kidney stones, and impaired concentrating ability. That is the ability to make the urine more concentrated and hold on to fluid with a risk of dehydration. Next slide, please. So this slide illustrates the progressive growth of kidneys from the CRISP study, Consortium for Radiological Imaging Studies in Polycystic Kidney Disease. And it shows that on the x-axis, it shows kidney volume in mLs or milliliters and age. And you can see that each individual has a progressive rise in their kidney volume during the 3 years of this observational study. And notably, GFR declined 4.3 mLs per minute only in those with a total kidney volume greater than 1500 ml. That is about 5 times normal. Normal kidney volume is about 300 ml. Next, please. This slide is a composite of MRI images of kidneys from 4 different individuals that represents different stages of progression. This is courtesy of Dr. Bay from the University of Pittsburgh. And you can see in this earliest affected individual, this is the T2 weighted image of the MRI. Cysts are white and the rest of the parenchyma or the tissue is dark. Over time, you see more and more cysts. You see that kidneys get larger and larger, and eventually the kidneys are almost completely filled with cysts. And on the right side is just a different way of looking at the MRI using the T1 weighted window. Next slide. Thank you. Well, total kidney volume is a biomarker of disease progression. It's been accepted by both the Food and Drug Administration and the European Medicines Agency as a prognostic biomarker, which is an indicator of faster kidney function decrease. It's clear that cysts are the disease and growth of kidneys is due to the growth of cysts. GFR, glomerular filtration rate, declines slowly in early disease. And generally chronic kidney disease progression, that is the reduction in GFR, occurs over multiple years. And this is a schematic of what this progression looks like. So this is on the x-axis, this is age. On the y-axis is kidney function. And you can see in the beginning, there's a stability or only a slight decrease in kidney function. And then over time, as kidneys get larger and larger, kidney function declines and the decrease in GFR, the increase in serum creatinine becomes more prominent. So the goal of our talk today is to how to measure total kidney volume and how to use it. So first of all, the kidney measurement of total kidney volume is best done with MRI, and contrast is not needed. A CAT scan can be used instead, and again, contrast is not needed. But of course, there's radiation exposure with a CAT scan. There's no radiation exposure with an MRI. And we know that ultrasound is not an accurate way to measure total kidney volume. So I'm going to briefly review some of the analytic techniques for calculating total kidney volume. And let me say right off the bat that research methods are the most accurate, but are not always available in clinical radiology departments. So these research methods were used in clinical trials, such as HALT PKD, Tempo 3-4, and TAME PKD. So the way this is done in the research methodology, each slice, the MRI is a series of slices of the done with the MRI machine, and each area of each slice is calculated manually or using computer algorithms. And once each slice is obtained, you add them all up. Prior to the use of computer algorithms, this took between 1 and 2 hours per exam. And fortunately, automated techniques have become available for research and clinical use. Well, an easier method is called the ellipsoid technique. And this is based on the assumption that the kidney is in the shape of an ellipsoid, basically a football, and uses easily obtainable measurements of length, width, and depth to then calculate total kidney volume. So I'm illustrating the ellipsoid technique here on this slide, and the figure shows the ellipsoid, and this is length and width and depth. Remember, this is a three-dimensional structure. And these are the same measurements in MRI images of the kidney. And so this is the length as you're looking at the person from front, and this is the length as you're looking at the person from the side. And we average these two measurements, sagittal and coronal length. And then the width and the depth are calculated by these red arrows that are shown on the slide. And the formula, no one expects you to remember it, as shown here on this slide. Basically pi over 6 times the average length times width times depth. And from that, we get a total kidney volume. So how do we use the total kidney volume? So the Mayo Imaging classification is a way to assess prognosis using total kidney volume. And I'm going to spend a lot of time talking about the Mayo Imaging classification. So total kidney volume is typically corrected for height to reflect the impact of body size on kidney size. So bigger people have bigger kidneys, smaller people have smaller kidneys, even in ADPKD. And this classification is only applicable to what we call typical ADPKD kidneys with cysts scattered throughout both kidneys. And these are so-called class 1 kidneys. Now, not everyone has such a straightforward kidney appearance. First of all, the rate of progression in Mayo class 2 kidneys is slower, which is good. Unilateral means only affecting one kidney. Segmental means cysts only in one part of the kidney. Asymmetric means one kidney affected much more dramatically than the other. Lopsided with big cysts that and a lot of normal tissue in between, and either one side or both sides atrophy or shrinkage of the kidneys. These are class 2. The rate of progression is slower, and one can't calculate the Mayo Clinic classification for these. That is, it's not meaningful. So again, I'm going to spend a lot of time on the Mayo Imaging classification. So this first graph here represents a group of individuals studied through the CRISP consortium in the Mayo Clinic, and it shows kidney volumes as a function of age. And these were findings as they existed in these individuals. And if you think about it, to get to a certain kidney size, your kidneys had to grow. So the investigators made the assumption that everyone started with a normal kidney volume around the age of 15 of about 150 mLs per meter that is corrected for height. So that's a normal total kidney volume. And over time, the kidneys grew. So if the kidneys are large, let's say at the age of 45, they had to grow more quickly than if they were small at the age of 45. And this is the beauty of the Mayo classification. So if you have large kidneys at a young age, this means that your prognosis is worse. And the rate of increase, for example, for class 1E is about greater than 6% per year, whereas class 1A, it's good to have class 1A or 1B, which reflects a slower progression, kidneys only growing at the rate of less than 1.5% per year. So if you're middle-aged and you have small kidneys, this is good. It indicates a low risk of progression. If you're middle-aged and have large kidneys, or if you're young and have large kidneys, this indicates a faster rate of progression. And the rates of progression estimated from the different classes, that is 1A, B, C, and D, etc., are shown on the right side of the slide. And so if you're Mayo class 1E, on average, the projection of loss of kidney function is about almost 5 mLs per minute per year. Whereas if you're class 1A, you're barely losing kidney function at all. Similar for males and females. And then if you project these rates of decline of kidney function over time, this shows the faster rate of achievement of kidney failure or end-stage kidney disease in the Mayo 1E group versus those that are 1A. And the black line on top shows the loss of kidney function that occurs in people who don't have kidney disease, so-called normal. So again, Mayo Class 1E reflects a rapid decline in kidney function. Class 1C, it's a steady decline, not quite as rapid, and Class 1A, barely any progression at all over time. Next slide, please. Now I'm going to show you three different individuals that illustrate this, this concept. So these are MRI images from three men, and they're all in their early 30s. Patient 1 is 33 years old, patient 2, 32, and patient 3, 30. And we look at their kidneys, and you can see the kidneys in this one patient are very different than the kidneys in patient 3. And if you calculate their total kidney volume corrected for height and plot them on this graph, you can see they show where their relationship to the Mayo classes. So patient 1 is class 1A, unlikely to progress. Patient 2 is class 1C, going to progress more than the patient 1. And patient 3 is going to progress the quickest because this individual has the largest kidney size at a young age. And you notice the GFRs, or the kidney function for each of these individuals, is basically normal, 97, 112, 114. So the Mayo class gives you a lot of insight into the risk of progression based on kidney size. And I think you can look at total kidney volume as really a crystal ball into the future of your kidneys. Now the Mayo Clinic calculator is online. If you search using your favorite search algorithm, ADPKD classification Mayo, you'll end up with this calculator. There's a introductory paragraph which it tells you what it's used for, and then you enter these numbers into these slots in millimeters. Right kidney, left kidney, and then you press a button and you get the volume of each kidney. And then if you add the height and the age, you'll end up with the Mayo classification. So I'm going to show you some atypical cases. These are three women. I'm not sure why we had three men in the first panel and three women in the second panel, but my female colleague, Dr. Cornack-Legault, picked these pictures. So this is a 44-year-old female with a very well-preserved GFR, and she's a class 2A, and she has what we would call an atypical bilateral presentation. So you can see that the left kidney here, these black structures are cysts, very large cysts, with a lot of normal appearing tissue or parenchyma in between these large cysts. And then in the right kidney, there's a few cysts, that one there, and then a few little ones, but most of the parenchyma is completely normal. So this individual has virtually no risk of progressing to kidney failure because this right kidney is very mildly affected. On the other hand, this is an example in the middle panel of so-called lopsided kidneys, which are dominated by very large cysts, extremely large cysts, with preserved kidney tissue between them. Again, this individual, 65 years old, has relatively preserved eGFR of 55, and she would also be in class 2A. And finally, this 68-year-old female has a very low GFR of 18. 20 is where you normally think about starting dialysis or getting a kidney transplant. This is a CT scan. There's multiple cysts, but these kidneys are small and shrunken. So this is bilateral kidney atrophy, and this would be considered a class 2B. And this individual has already progressed and would not be eligible for any therapies based on Mayo class. So what is rapidly progressing ADPKD? And I'll point out right off the bat, this has not been defined by the Food and Drug Administration. So it means large kidneys at a young age, Mayo Imaging class 1C, 1D, or 1E. There's other ways of looking at this. So an average kidney length greater than 16.5 centimeters in someone less than 45 years of age. By DNA mutation analysis, PKD1 is the more severe form of PKD, so that implies a more rapid progression versus PKD2. The pro-PKD score is based on the genotype, that is PKD1 and 2, the gender, and complications less than 35 years of age. So if you have hypertension or blood in the urine below the age of 35, that increases the risk of progression. We don't always measure the mutation, but kidney failure in a first degree relative before the age of 55 suggests PKD1. And the other way of documenting rapid progression is an average annual decrease in GFR greater than 2.5 mLs per minute over 5 years, or greater than 5 mLs per minute over 12 months. So how do I assess the risk of rapid progression by imaging? Well, again, you must have typical ADPKD with diffuse and bilateral cystic involvement, that is cysts throughout both kidneys. Mayo classes 1C, 1D, and 1E are considered rapid progression. You exclude those with atypical involvement, that is the Mayo class 2. You can estimate the total kidney volume from an MRI or a CT scan using the ellipsoid formula, as I've shown you. And ultrasound is not sufficiently accurate to measure total kidney volume. So once again, rapid progression, Mayo classes 1C, 1D, 1E. These are the rates of GFR decline. And similarly, these are the GFR slopes based on the Mayo class. So this is 1E, the most rapid decline to kidney failure, 1D, a little slower, and 1C, slower than that. And then 1A and 1B, much slower. So I'm going to talk about the optimal management of ADPKD. So first, determine if you are a rapid progressor. So this should be the first thing that your nephrologist does when they meet you at the beginning. All patients should receive optimal management in any case. So measures that are proven to slow the growth of total kidney volume include blood pressure control, and this level of 110/75 applies if you're younger, ages 18 to 50, and your GFR is greater than 60. Others, we target 130/85 or lower. Moderate sodium restriction, and maintaining a normal body mass index. We know that people who are obese progress more quickly. And measures not proven to slow the growth of total kidney volume are increased hydration, that is water drinking in large volumes, and cholesterol treatment, although cholesterol treatment is good for your heart to prevent heart attacks. So increased hydration is good. It decreases the likelihood of kidney stones. We know that ADPKD kidneys have impaired ability to concentrate the urine, that is to hold on to water, and thus there's an increased risk of dehydration. A recent large study of large water intake in ADPKD was completed in Australia and was published in November of 2021 in an online form of the New England Journal. And this study showed that larger hydration did not slow the total kidney volume growth or eGFR decline. However, about half of the participants did not reach the hydration goal. So the study was inconclusive as to the benefit of increasing hydration or water intake. So it may still be beneficial. So let's start off. Let's say your nephrologist goes through the calculation and you're not a rapid progressor. Well, first thing you should do is enroll in the PKD Foundation patient registry. Depending on kidney anatomy and patient factors, it's best to individualize the approach. And of course, fully implement optimized management as appropriate. I always recommend that people consider participating in a clinical trial if eligible. The present existing ongoing clinical trials exclude slow progressors, however. So if you are a rapid progressor, what are the next steps? Well, of course, you should still enroll in the PKD Foundation Patient Registry. You should fully implement optimized management, as I've outlined, and consider participating in a clinical trial for which you are eligible, or consider Tolvaptan, which is approved by FDA in 2018 for adults at risk of rapidly progressive PKD. So I'm just going to briefly mention the current interventional clinical trials for ADPKD in the US. These can always be found at clinicaltrials.gov. You just search for ADPKD. So these include caloric restriction and time restricted feeding, pravastatin in ADPKD at the University of, both of those are at the University of Colorado. The Falcon study of bardoxolone, which is a phase 3 trial at multiple centers, and the action study of lixivaptan, which is a phase 3 trial at multiple centers. Vasopressin is a hormone that regulates your water balance. And if we block it or shut it off, we slow cystogenesis. So in these 4 animal models, when we blocked vasopressin, shown on the right side of this panel, you block cystogenesis. In these rats encouraged to drink large amounts of water by putting sugar in the water, the rats that drank large amounts of water had smaller kidneys and fewer cysts. And if you completely knock out vasopressin, that's AVP, by breeding PKD rats with a rat that lacks vasopressin, you basically eliminate cystogenesis. And then if you give back vasopressin in the form of this drug, DDAVP, you make cystogenesis work. So vasopressin has a very important role in the progression of ADPKD. This study, the TEMPO study, published now 10 years ago in the New England Journal of Medicine, shows the effect of Tolvaptan. It decreases the rate of kidney volume increase by half, from 5.5% in the placebo to 2.8% in the Tolvaptan treated group. In addition, it slowed the rate of kidney function by about a third. It slowed the rate of kidney dysfunction by about a third. In addition, Tolvaptan reduced kidney pain. So this is the placebo group, this is the Tolvaptan group, and you can see there's a less incidence of pain events in those that were treated with Tolvaptan. In the 3-year trial, 10.1 versus 16.7%. In addition, Tolvaptan significantly reduces hematuria, that is blood in the urine, kidney stones, and urinary tract infections. In the second large multi-center study of Reprise, this was done in individuals with lower GFR. Tolvaptan reduced the decline in kidney function compared to placebo by about 1.3 mLs per minute. So 2 large multi-center studies show a benefit of using Tolvaptan. And as I mentioned, this was approved by the FDA in 2018. So if you're going to consider initiation of Tolvaptan, you must establish the diagnosis of typical ADPKD with the risk of rapid progression. Mayo classes 1C, 1D, or E. Generally, we recommend that the GFR be above 25, ages 18 to 55, which maps with those that were treated in the clinical trials. You exclude people who can't take Tolvaptan. Everyone must enroll in the risk evaluation and mitigation strategy. Because Tolvaptan caused elevation of the liver function test in about 5% of individuals, there's a very strict monitoring program. And then as a physician, you need to educate the patient about the aquaretic side effects. You pee a lot, so urine output is greatly increased. There's more frequent bladder emptying, and you'll need to get up multiple times overnight with potential sleep disruption. So as mentioned, the liver function tests need to be monitored closely. These include the ALT, AST, and bilirubin at baseline, 2 weeks, 4 weeks, and every week for 18 months, and every 3 months ongoing. Other laboratory studies such as the sodium and the creatinine, alkaline phosphatase, and uric acid. The water intake needs to be adjusted for the level of sodium in the blood, and you need to adjust the dose based on the tolerability and the pre-dose urine concentration or osmolarity. So you want the urine when you're taking Tolvaptan to be very clear. You don't want to have dark yellow urine, and we can measure this in the lab, in the clinic. So the side effects of Tolvaptan, the aquaretic effects. So again, frequent and large amount of urine production during the day and overnight. And then the liver effects that I've mentioned. About 5% of people taking Tolvaptan developed abnormal liver function blood tests, which have been found to improve after stopping the medication. And this is the reason for the monthly measurement of liver function test under the REMS. Tolvaptan is dispensed by a limited number of specialty pharmacies. If you don't get your blood test, you don't get the drug prescribed. And the prescriptions are given every month in the beginning and every 3 months after the 18-month period. So the theoretical benefit from Tolvaptan is shown on this slide based on projections from the TEMPO study and the REPRISE study. So if you start Tolvaptan early, you may delay kidney failure by as much as 7.3 years. And that's true whether you use the numbers from the REPRISE study. So 6.8 is the projection from the REPRISE study. If you start Tolvaptan late, that is when your GFR is 30, you might gain between 2.3 or 1.5 years delay in kidney failure. So summary and conclusion. Assessment of total kidney volume is pivotal to understanding your risk of loss of kidney function. And notably, only 33% of those who took the healthcare access and utilization module of the PKD registry had a total kidney volume measured. 39% didn't know. Using the Mayo classification gives good insight to your potential disease course. Eligibility for some clinical trials requires assessment of total kidney volume, and eligibility for Tolvaptan treatment is best determined by assessment of total kidney volume along with other patient factors. So thank you for your attention. A question and answer session now follows. I'll leave this slide up. I encourage you and those who haven't to sign up for the PKD Foundation registry, which will help us learn more information about the course and the manifestations of polycystic kidney disease from a patient perspective.
All right, thank you so much, Dr. Perrone. And I'm going to the questions. All right, one question is, how does taking Tolvaptan affect TKV?
So the question is, how does Tolvaptan affect TKV? Tolvaptan slows the rate of increase of total kidney volume. The effect is most prominent in the first year of Tolvaptan therapy. It does not stop the progression, but it slows it by about half.
Okay. All right. And let's see what the other, once TKV is initially measured, one person says, are subsequent measurements recommended at later intervals?
So that's a very important question, and there's a lot of debate and discussion in the field about that. So for example, if you measure a total kidney volume and you get a certain measurement of the Mayo class, and you measure it 3 years later, we expect the Mayo class to remain the same, even though the kidney volume might change. We don't know if, for example, let's say you qualify for Tolvaptan and you're taking it, we don't know how to use kidney volume to judge the effect of Tolvaptan unless you had a series of measurements prior to starting Tolvaptan, and we could compare those. But we can't look at your result in an individual patient and know that you benefited or not.
Another question is, what if a PKD patient has only one kidney?
So if a PKD patient only has one kidney, but it's diffusely involved with PKD, with cyst, I would look carefully at that individual, and if they otherwise met criteria for Tolvaptan, I would consider that. I'd probably double the measured kidney volume in order to use the Mayo class. But if the kidney is abnormal, then one looks at that. If you have a normal kidney and a PKD kidney, then that person would be a 2A. It would not qualify for Tolvaptan.
Okay. Next question, what value, if any, does total kidney volume have after ESRF or kidney transplant?
So once you reach kidney failure, ESRF or transplant, we're not interested in the volume of the kidneys as it might reflect the decline in GFR, because GFR has already declined. We would be interested in knowing the kidney volume in terms of complications, pain, other issues, and in terms of further potential treatment. The natural history of polycystic kidneys after kidney transplant is that the kidney volume decreases by about 20% over the first year. Now, if one is having symptoms that are thought to be related to the native kidneys after kidney failure or kidney transplantation, then there would be value in assessing the kidney size to see whether they need to be, whether one or both kidneys needs to be removed.
Next question, I am from Brazil. May I register myself at PKDF?
Right now, the registry is only open to people in the United States, but you should check with your doctors in Brazil because they may be monitoring your PKD in a registry there.
Next question, do you see differences in TKV classifications between members of the same family?
Yes, members of the same family, even though we think they have the same genetic mutation, may progress differently, both in terms of kidney volume and GFR decline. We don't know the reasons for that.
All right, next question. Can you speak more to the potential decrease in kidney function decline with Tolvaptan? I watched a talk by the Mayo doctor involved in the trials who stated for every 5 years of taking Tolvaptan, one can roughly expect to gain 1 year of kidney function. Does this match more recent findings of the drug?
The information we have about Tolvaptan is largely from the clinical trials that have been done. There's been a few small studies looking at long-term benefit. There's a series of about 90-some patients from Mayo Clinic that were followed for up to 10 years because some of these patients were on the very earliest studies of Tolvaptan. And the rate of decline, the slowing of the rate of decline seems to hold even after that long.
Next question. What does a patient do if their nephrologist does not know what TKV is or how to measure it?
Well, if your nephrologist doesn't know what TKV is or how to measure it, I guess I would try to have a conversation with that nephrologist. If they're not interested in that, well, I'd say find another nephrologist. There are many resources available to nephrologists to learn about total kidney volume and how to measure it. In addition, some radiology departments will measure total kidney volume for the nephrologist. So that's another way of getting the result.
Next question, are vasopressin antagonists on the horizon to be used for PKD?
You mean vasopressin antagonists other than Tolvaptan? Well, there's a trial, the ACTION trial of Lixivaptan. Lixivaptan is a vasopressin receptor antagonist, and it's now being studied in ADPKD. And based on modeling studies, it's possible that Lixivaptan has less effect than Tolvaptan on the liver. So if that was found to be true in the clinical trial, that would be beneficial. But right now it's under clinical trial, which is really just started.
Next question, does sclerotherapy affect TKV progression?
So what is sclerotherapy? Sclerotherapy involves draining cysts, usually typically very large cysts, and injecting detergent or alcohol into the cyst to kill the cells that line the cyst. So if you have cyst drainage and sclerotherapy, your kidney volume will go down. There aren't any long-term studies looking at the effect of sclerotherapy. The group in Toronto, York Pay, have looked at sclerotherapy, but we don't have long-term data yet.
All right, that looks like that was all of the questions. Let's see. Yep, that was all of the questions. So since there are no more questions, we'll go ahead and wrap this webinar up. I want to thank Dr. Perrone so much for lending your expertise to our audience. We really appreciate it. And thank everyone for joining us for this webinar. Again, this recording will be available on the PKDF website. Thank you again, and we will see you next time. And everyone is thanking you, Dr. Perrone.
Thank you very much.